بسم الله الرحمن الرحيم. هنبتدي السيشن على البيريبروستاتيك جوينت انفكشن، ودي بتبقى من الحاجات الانترستنج شويه لانها فيها ابديت الفتره الاخيره كتير، سواء في البريفنشن او التريتمنت. والحقيقه حبينا نعمل السيشن دي تبقى كومبايند مع الانفكشن كنترول يونت في عين شمس، وكمان من خارج عين شمس. فيشرفنا وجود الدكتوره امنيه من الانفكشن كنترول، استاذ الميكروبيولوجي في عين شمس. وطبعا معانا الاستاذ دكتور ابراهيم الجنزوري، استاذ المفاصل وعضو الجمعيه الاي سي ام للجايد لاينز للمانجمنت اوف بيري بروستاتيك انفكشن. وهيجوين كمان معانا الدكتور مصطفى الفيشاوي، ده من الازهر سنتر فور ذا امينولوجي، وبرضه من الناس اللي ليها باع في المانجمنت اوف بيري بروستاتيك انفكشن والاورثوبيديك انفكشن كمان بالذات. وحبينا نعملها مش في صوره محاضرات، في صوره بانلز وكيس بيست. ومعانا طبعا من الاسم الدكتور احمد سيد قطب والدكتور احمد سعيد يونس، المدرسين بقسم جراحه العظام، فهم هيقدموا الحاله وناخدها في صوره اوبن ديسكشن من غير محاضرات ان شاء الله. دكتور احمد يونس هيبتدي.
السلام عليكم، ازيكم؟ بنرحب باساتذتنا استاذ دكتور ابراهيم الجنزوري ودكتور وائل سمير، وطبعا دكتوره امنيه من قسم الكلينيكال باثولوجي، وفي انتظار دكتور مصطفى ان شاء الله انفكشن كنترول. احنا اول حاله هنعرضها هي كيس 65 years old female patient عندها bilateral knee osteoarthritis. الكوموربيدز بتاعتها البيشنت دايابيتك، الدايابيتس بتاعها ان كنترولد، وكاردياك عندها اي اف، والبي ام اي بتاعها اكتر من 40، وعندها هيستوري في كرونيك ليفر ديزيز. طيب اول سؤال هحب اسال الدكتور ابراهيم الجنزوري، هل في بري اوبراتيف لابس زي مثلا اليورين اناليسيز او سكريننج فور مال نيوتريشن، او لابس معينه سكرين بيها البلاد شوجر او الجلايسيميك كنترول قبل العمليه؟ وهل مهم اعملها ولا لا؟
هو طبعا كل ما المريض يبقى عنده كوموربيديتس اكتر، كل ما بنحاول ان احنا نوبتمايز العيان الى احسن نقطه نقدر نوصل لها. في كلام ستاندرد بيتعمل، لازم طبعا تشوف الليفر فانكشنز والكدني فانكشنز، بتشوف الجلايسيميك كنترول، واحسن طريقه يتشاف بيه هو الهيموجلوبين اي 1 سي، ده بيديك الفولو اب على مدار 3 اشهر. لو محتاج حاجه اسرع من كده شويه، في الفركتوزامين ده بيدينا جلايسيميك كنترول اوفر 3 اسابيع. بلس ان انت لازم العيان في البيري اوبراتيف بيريد يكون الجلايسيميك كنترول بتاعه مظبوط. بتشوف النيوتريشن ستيتس بتاعت العيان، اكتر حاجه بنستخدمها هو الالبومين، ممكن تستخدم الليمفوسايتس، في كذا 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 ميجر، في كذا حاجه تميجر بيها. الموست كومن يوزد هو الالبومين. الالبومين، الاي اس ار والسي ار بي، اي دونت ثينك ان ده ستاندرد هم بيتعمل unless العيان عنده روماتولوجيكال كونديشن او انت شاكك في حاجه عاوز تشيك، لكن اتس نوت ا ستاندرد لاب بيتعمل. اليورين اناليسيز في ديبيت، هل ده should be a routine pre-operative investigation ولا لا؟
تمام.
but it's not standard في كل العيانين. بيزيكلي ده اللي بنعمله. لو اليورين طلع فيه بكتيريميا او
تمام.
واي بي سيلز عاليه، it depends ده سيمتوماتيك ولا مش سيمتوماتيك. لو
تمام.
سيمتوماتيك we should manage او delay the operation. if it's asymptomatic bacteria المفروض ان احنا we ignore الكلام ده.
تمام. طب دكتوره امنيه، حابب اسال حضرتك عن الميرسا سكريننج والنيزل ديكولونايزيشن وسكين ديكولونايزيشن، او هل انا ممكن اسكرين كل العيانين من الميرسا لازم، خصوصا لو العيانين الالكتيف قبل الجوينت ارثروبلاستي؟
بسم الله الرحمن الرحيم. طبعا لازم نعمل الميرسا سكريننج لكل
تمام.
العيانين اللي داخلين اورثوبيديك سيرجري. بص، انا بقيت المحاضره شفتك مش كاتب ان هو نو نيد فور يونيفرسال سكريننج، بس هو لا، هو في نيد عشان تعمل التارجت ديكولونايزيشن. انا فاهمه انت عايز تقول ايه. عايز تقول انه انا هعمل لكل ديكولونايزيشن وخلاص، هحط
بالظبط.
للناس في النوز والكلوروهكسيدين. طيب هو احنا بنتكلم هنا على كوست افكتفنس. هل هي كوست افكتيف لو انا في حد ما عندوش ميرسا يعني ميرسا كولونايزيشن على السكين او على النوز، ان انا اديله؟ نعم. اوكي.
اوكي.
طيب Okay, I will start over. Okay, first of all, I would like to say that MRSA screening is mandatory
Okay.
for all orthopedic surgeries, especially if we are using an implant. If we are talking about universal screening,
Yes.
yes, we should do a universal screening, and we shouldn't do a universal decolonization because it is a matter of cost effectiveness. Okay, when we say that someone is not colonized with MRSA, and I give him 5 days mupirocin 2 times per day and 1 shower chlorhexidine, I would say that this is not a cost effective. Okay, we don't need that. We just do MRSA screening from the nose, from the axilla, and from the groins. Okay, and go for a targeted decolonization. Who has MRSA in his nose or skin, we do a decolonization for him. Other than that, it is not mandatory.
Okay, if the patient is a MRSA carrier, how long will you postpone the operation, or we just decolonize and he will enter the operation?
What do you mean by MRSA carrier? In throat or in nose?
In nose or throat. MRSA carrier positive.
Yes.
I screened the patient and he's a MRSA carrier positive.
Yes, I should decolonize. I should decolonize. I should give him mupirocin 2 times per day,
Okay.
and he should take a shower with chlorhexidine once per day.
Okay, do you colonize with mupirocin only, or you use other substance like povidone, iodine, or something?
We might use povidone iodine
Okay.
according to availability. We might use it.
Okay. The lab urine analysis is CRB. Albumin must be more than 3.5 milligram per deciliter. Pre-operative blood sugar must be controlled, and glycemic control should be monitored with hemoglobin A1C. Dental screening and MRSA screening. دكتورة أمنية opinion that it is mandatory to do MRSA screening, but recently universal MRSA screening is not needed as nasal decolonization, as it's not cost effective. We do nasal colonization, and the skin decolonization is strongly recommended pre-operative for elective cases. Okay, patient prepared for surgery and we did skin decolonization. Dr. Ibrahim, which antibiotic agent we give in primary cases, and do you change the prophylaxis for high-risk patients like patients with previous septic arthritis or patients with comorbidities like diabetes, chronic kidney disease, or trauma?
For the primary cases, I think the routine protocol is variable from one place to another. However, the second generation cephalosporin or first generation is the most commonly used all over the world. If you have a previous septic arthritis, as you know, according to the study that you have been doing, we should change the type of antibiotic according to the organism that was there during the septic arthritis. And also, we should extend the period of prophylaxis more than the standard period, which is normally 24 to 48 hours.
Okay. Dr. Wael, the timing of preoperative prophylaxis, time of giving the antibiotic, and can we repeat the dose during the operation?
بص الريكومنديشن ان احنا بنستارت 1 اور 2 او هاف ان اور بري اوبراتيف قبل التورنيكي ونستمر. ده ريكومنديشن 24 اورز، انما اكشوالي في مصر احنا بنكستند شويه. انا يعني ريسنتلي بقيت 2 دايز اللي هم في الادميشن واي دونت بريسكرايب اورال انتيبيوتكس للعيان تاني بعد الديسشارج.
During the operation, if the length of the operation was lengthy, can you repeat another dose?
الاوبريشن على حسب الهاف لايف بتاع الانتيبيوتكس. لو انت يعني دبل الهاف لايف بتاعته بتدي انتيبيوتكس، ولو انت هتدي فيه ماسيف، وده يمكن ما بيحصلش كتير طبعا الا في حالات الكومبلكس ريفيجن. يعني لو انت هتدي بلاد ترانسفيوجن، الوجينيك بلاد ترانسفيوجن، ميجور بلاد لوس، او انت هتدي بلاد، يبقى انت بتدبل الانتيبيوتكس تاني.
تمام. The most commonly used antibiotic agent for perioperative prophylaxis is cephalosporin, particularly cefazoline. Patients with previous septic arthritis, either we extend the antibiotic duration for 2 to 14 days after operation or give pathogen-related prophylaxis. Patients, antibiotics may be tailored according to the high-risk population or regional microbial epidemiology. The timing is within 1 hour of skin incision. The dose we give a single dose can be repeated 24 hours during hospital admission or 48 hours. In obese patients, the antibiotic prophylaxis should be dose adjusted, repeated if the length of the operation exceeds 2 half-life from the time of the administration and the blood loss exceeds 200 milli or if there is large volume of fluid replacement. However, the operation was done successfully. Dr. Mustafa, I'd like to ask you.
The regional microbial epidemiology is called an antibiogram. The regional microbial epidemiology, which you mentioned the previous slide, is the antibiogram, which is done on a cumulative basis, and it comes from the microbiology lab. As you can see, you said cefazoline. Cefazoline is the protocol, the universal protocol for all policies as a preoperative antibiotic. Sometimes, especially in Egypt, cefazoline become resistant, and I have asked a lot of professors, what if cefazoline in our antibiograms is resistant? Can we change it to another thing? And the answer was debatable. It was a controversy about this, but I think we should change it because our staph coagulase negative is resistant to cefazoline. So we should go ahead for another antibiotic, which might be in the same class, cephalosporin class 1, and I don't mean to change it to class 2 or class 3. Okay, this is my comment.
Okay.
Okay, so regarding the point that Dr. Omnaya just mentioned, we need to address very important. When she said that this cefazoline prophylaxis was based on international guidelines. So whenever you have any international guidelines, it should be tailored to the local antibiogram. So if she gives you an information that the cons coagulase negative staph in your institution might be resistant to cefazoline, then you should choose another option. Also, very important point is that whenever we plan any orthopedic procedure or even any procedure, you need to get MRSA screening. And I know that you're gonna discuss this, but this is important because whenever you have a patient that is MRSA positive, then you will need to prescribe in the prophylaxis cefazoline plus vancomycin. It's not only vancomycin, because vancomycin is a slow antibiotic. So you will have to combine cefazoline plus vancomycin. And vancomycin need to be addressed with the anesthesiologist because vancomycin by default is a slow infusion. So then this will affect the OR protocol.
After decolonization, if a patient with a
I would like to comment about something that you said, that the recent guidelines said it is a cost-effective to colonize and no need to do immersive colonization. This is as well based on an international policies. Sometimes here in Egypt we don't have a Bactroban. So we should think about our availability of drugs. So I recommend here in Egypt to do immersive screening and do a targeted decolonization.
Okay.
So do you recommend universal decolonization for all the patients? Because you know that there is a problem with microbiology lab in doing the test, reporting the test, and reporting it on time. Because there was some
I am commenting on the optimum situation. When I have a good microbiology lab, I should report MRSA as intended, and I should do the work at the optimum level. I will not correct the wrong procedure in microbiology lab that I give all the patients Mubrisi. So the first step is to optimize the lab. Then I will do targeted universal screening and then targeted decolonization.
Okay. And very important, the question of Dr. Ibrahim, because he wanted to ask about test of cure. So is it recommended? Because I told him no. Yeah, that's an answer. So no test of cure after MRSA screening.
From your experience in the infection control, do you have a rough idea about the prevalence of specific types of infection in our joint replacements? Yani, what is the prevalence or identification of the organism according to the highest one to the least one?
Okay, so I think we presented this lecture before about the data in Egypt. So usually in like all over the world is different than in Egypt. So all over the world you will have Staph aureus and coagulase negative staph as a predominant organism, mainly more than 80 to 90%. Unfortunately in Egypt we have gram negatives and especially this nasty Klebsiella carbapenem resistant. So that's the problem that we really have. And this Klebsiella, there is no treatment for it. There is no targeted treatment. There are antibiotics that work on it. But a true antibiotic for this Klebsiella that we have in Egypt, there is none till now.
As an average, it is at 20%, but 20%. But in some settings, I worked with a burn patient in a burn hospital. There was a huge number of MRSA. It might be 40 or 50. But this is specific for this setting only. But in my general specialty hospital, I find it as 20%. This may be attributed to that burn patients was referred to our burn hospital from other hospitals. So they are chronic patients and they can catch the MRSA from the previous clinical setting, from the other hospitals. It's hospital acquired, I mean.
Okay, Dr. Mustafa, I would like to ask you about if there is some OR regulations that can decrease the risk of infections, surgical factors. When I start irrigation of the wound, what is the best irrigation solution, the volume of irrigation? When I add antibiotic to irrigation, is it beneficial? When I add a local antibiotic powder, is it beneficial to prevent infection or not?
So regarding the first question, whether there is an irrigation fluid that's better, I don't think there is like a meta-analysis to answer this question. Although some doctors prefer like certain fluids. Regarding the antibiotic added to the irrigation, also there is anecdotal evidence that many doctors say, I use vancomycin for irrigation, I use amikacin for irrigation for gram negatives and so. But like fixed data in the guidelines, I don't think they are mentioned. There will be new guidelines that will be within few days. Maybe then we will discuss afterwards and we will mention all the recommendations. That's when it will be held in Turkey. Regarding local antibiotic, yes, we use local antibiotic mainly in our patients that have gram-negative infections. And the reason for that is that we have gram-negative infections that actually, as I just mentioned, no treatment available. So we will try to do whatever we can. So we use colistin locally. We use colistin in irrigation fluid. We use amikacin. But the most important thing that everybody should know is that whenever you use an antibiotic for either irrigation or for local treatment, this antibiotic you may have also toxicity. And there has been reports of amikacin level that's measurable after amikacin irrigation or using, for example, another aminoglycoside like gentamicin when you use it in the sheets. The gentamicin sheets.
Although most recent literature does not support the use of local antibiotics on irrigation or antibiotic powder on the wound. So you are always using them?
As I just mentioned to you, I know that the guidelines already, I said there is a debate, but the problem is that whenever you have a carbapenem-resistant infection, and that's a problem, we should have our own guidelines for management, especially in carbapenem-resistant infection. The MRSA of Egypt is similar than the MRSA elsewhere all over the world. Okay. It's fine. The coagulase negative staph, it's similar. But the problem we have the highest rates of carbapenem-resistant infection in the whole world. So we should set our standards. The other problem is that there are other antibiotics that are used in the US and other Western countries that we actually don't have in Egypt. So we use colistin. I will just say, if just one example, I did my fellowship in Pittsburgh, 2 years infectious disease. I used colistin only once in 2 years. Here in Egypt, it's like 20 to 50 times per day. So you should imagine the difference.
Okay. What about operation room regulations and surgical factors like excessive soft tissue dissection? Dr. Wael. Number of personnel in the OR, the frequency of door opening and laminar flow OR.
تاني انا الحقيقه مش سامع حاجه خالص. الاوبريشن روم في حاجه ميسد هنا. طبعا النمبر اوف بيرسونيل والفريكونسي اوف دور اوبننج دي من الحاجات مهمه جدا. اللامينار اير فلو هنخش بقى في ساينتفك ديبيت، يعني هو لامينار ولا اكسبوننشال وفايدته، واللامينار اير فلو ده with سبيس سوت ولا من غير سبيس سوت، يعني هيبقى الموضوع واسع قوي. اذا المستشفى اللي انت بتشتغل فيها امكانيه لامينار اير فلو with سبيس سوت، اهلا وسهلا، دي احسن حاجه في الدنيا. النمبر اوف بيرسونيل والفريكونسي اوف دور اوبننج لازم يزيد عليهم فاكتور اخر، وهو موفمنت انسايد ذا ثياتر. يعني هنفترض ان انت عندك اللي موجودين في اوضه العمليات 4، بس في منهم واحد عمال يلف ويروح ويجي ويلف ويروح ويجي ويفتح العلبه ويرجع ويفتح العلبه. الموفمنت دي بتكرييت اير كارنتس، والاير كارنتس دي هي العدو بتاعك، عشان هي دي اللي هتاخد من البيلو سيرفيسز للاباف سيرفيسز، يعني من الارض للسماء. فانا مش ممانع في اللي مكتوب، بس يا ريت نكتب نمبر اند موفمنت اوف بيرسونيل.
تمام.
اللامينار فلو از نوت بروفن تو ديكريز ذا ريسك زي ما قلت لحضرتك.
تمام.
وفي ناس عكس هذا، بدليل ان في لسه سنترز كتيره جدا بتصرف مئات الالاف من الدولارات في اللامينار فلو والسبيس سوت. خدت لي بال حضرتك؟ اللي فاضلين فوق دول لو زودت عليهم الموفمنت تبقى كويس قوي.
تمام.
حكايه الفريكونسي اوف دور اوبننج دي يا جماعه، الدكتور الله يرحمه فاروق برج كان بيقفل الباب من جوه بالجنزير. يعني نخش في الارتروبلاستي، الباب عين شمس التخصصي ده كان فيه بتاع حديد كده عريضه شويه، كان يجيب جنزير ويقوم قافل الباب لحد ما العمليه تخلص. عشان ايه؟ كل شويه نايب عايز يخش يتفرج، مش عارف، واحد عايز يسال سؤال، بتاع البنج اللي في الناحيه الثانيه داخل بيسلم على بتاع البنج اللي في الناحيه دي. فعدد المرات اللي بيتفتح فيها الباب برضو مش كفايه لوحده. في فاكتور تاني ما اتقالش هنا،
موفمنت.
لا، غير الموفمنت بقى، الاهم من الاير فلو ان يبقى عندك بوزيتيف بريشر. يعني اوضه العمليات دي البريشر اللي فيها اعلى من الطرقه اللي بره، فقام لما الباب يتفتح الهواء يطلع ما يخش. تاني بقى حضرتك. عموما هم دول الثلاثه فاكتورز اللي انا بهتم بيهم، ان يبقى فيه بوزيتيف اير بريشر، عدد الناس يبقى قليل، حركه الناس تبقى قليله، واذا كان عندك حاجه زياده كمان يبقى خير وبركه. يعني مثلا ما اعرفش في حد فيكم راح الاندو كلينيك بتاعت هامبورج؟ طيب الاندو كلينيك دي فيها 3 ليفل اوف انتي سيبتيك بروسيجرز. بتخش حضرتك تقلع الهدوم وتاخد دش وتلبس هدوم لونها اخضر وصابون اخضر، وبعدين تطلع من اير لوك زي بتاع الغواصات. اير لوك، الهواء اللي انت داخل عليه مش ما جاش معاه هواء من الاوضه اللي انت فيها. لما تخش الاير لوك تخش تغير تلبس هدوم تانية خالص بيضة وشبشب ابيض او كلوج ابيض، وبعدين تطلع من دي على اير لوك تالتة لو هتعمل عملية. لو مش هتعمل عملية السكند زون دي فيها الحته اللي هي انت ممكن تقعد تخطط فيها للعمليه، 2 دكاتره يتكلموا مع بعض، البنج العيان قبل ما يتبنج يخش، يبقى في حتت بتعمل ما مستحيل، يعني مستحيل تفتكر ان هو هيجي باثوجينيه واحده تخش في الجرح، ومع ذلك طبعا بيبقى عندهم برضو انفكشن. يبقى الموضوع بتاع اللي في ايدنا احنا اللي هم ال3 حاجات يا ابو حميد اللي احنا قلنا عليهم: البيرسونيل، العدد، الحركه، البوزيتيف بريشر، والباب ما يقعدش ايه، ما هو البوزيتيف بريشر والباب دي حاجه واحده.
تمام. Postoperatively, the patient desatted, experienced arrhythmia and mild pneumonia, and admitted in the ICU for 5 days. On day 6, the patient spiked the fevers 37.8 to 38.5 and had persistent wound discharge. طيب دكتور وائل, how we differentiate between non-infectious and infectious discharge? And which serum markers can help in the early postoperative period? Should I remove, if I am putting a drain, should I remove it or leave it until the discharge stops? Should anticoagulation be adjusted? The vac or negative pressure therapy is useful? And should I swab the...
الاول الوند، تعريف الوند تشارج من الارثروبلاستي ان في عندك وود بلادي ديسشارج او سيروسانجنس لمده 48 ساعه ل 72 ساعه. البرزيستنت ووند ديسشارج الديفينيشن بتاعه ان انا عندي ووند ديسشارج اكتر من 72 ساعه. هنا المفروض ان انا ابتدي اديل ويز. اول حاجه هديل ويز هو الانتي كواجولانت ادجستمنت. ممكن العيان ده يكون عنده مشكله في الانتي كواجوليشنز، واحيانا لو هو حتى ما عنده مشكله، طالما ان العيان بدا يموف ويتحرك وانا مطمئن الى شويه، انا ممكن استوب الانتي كواجولانت فور وايل لحد ما احسن الووند تشارج. ده اللي بتعامل فيه من اليوم الثالث لليوم السابع. تاني حاجه برضو بشوف الالبومين ليفل. بالنسبه للفيفر ما هيش علامه، البوست اوبراتيف بالنسبه للفيفر ما هيش علامه ان العيان ده انفكتد. انا في ماي براكتس موست كومنلي الفيبر دي بتبقى نتيجه ديهايدريشن، ان العيان ده ما بياخدش جود فلويد او ريهايدريشن كويس بالظبط كانيولا، فبياخد لو اول ما بياخد الفلويدز الفيفر دي بتتحسن. في الفتره ديت انا من اليوم الثالث لليوم السابع او اليوم العاشر ممكن استخدم اللي هو الكلوزد سيستم بتاع الفاك، ان انا استخدمه علشان اقلل الديسشارج. لو بيرزيستنت بعد الكلام ده على اليوم العاشر I should go for open واتعامل معاه لا ان ده start of persistent wound discharge not responding لكل conservative management اللي انا عملته. السي ار بي طبعا والسيرم اناليسيس مش هيبقى مفيد قوي بالنسبه لي، لان هو بيعلى بوست اوبراتيف وتبتدي البيك تنزل. انما بعد كده طبعا انما انا باخده بس كلاند مارك، انا اشوف الترند بتاعه عامل ازاي. يعني انا هشوفه الاول، مثلا انا بدات على اليوم الثالث او الرابع اشوف السي ار بي واعيده تاني بعد 3 ايام اشوف الترند بتاعه اذا كان فوق. طبعا علشان اقول ان السي ار بي ده ممكن يكون ريليتد للانفكشن لازم يكون فوق ال100 مثلا. ان في الكرونيك انا فوق ال10 باكسبت ان هو ده ماركر للانفكشن.
تمام دكتور. احنا بس we are running out of time so we طيب when I have persistent wound discharge I should decrease the activity and encourage immobilization, adjust the anticoagulation and evac and decrease the discharge in 24 hours. Drain, increase blood loss and the need for transfusion may need to increase the risk of infection. Dr. Mustafa, should I swab a draining wound?
Usually no. If your patient has like a sinus or like a draining wound, mainly the bacteria that you will get with the swab are the skin flora of any patient. So if you swab me, you'll know. So usually no, but sometimes it can be needed. For example, if you have, I have seen some patients that we do it, and this is important. If you have, for example, a patient coming from an endemic country with TB and has signs of TB, and you need to screen whether he has a positive TB PCR. So you can do from the sinus, because usually TB is not present on the flora of the skin. So that's the exception. Otherwise, for the regular work, you shouldn't get any swab.
Okay.
I agree with Dr. Mustafa. Yes. Most probably you will get skin contaminant only.
Okay. On day 8, the patient experienced high-grade fever, 38.7 to 39, persistent offensive odor discharge, redness, hotness of the suture line.
تاني يوم فضتها 300 برضو، فهتكيب الترين لحد ما تقل وتقل قد ايه، وايه الماكسيمم تايم؟
Normally, there's a trend all over the world to stop using drains in primaries and revision and all the cases. However, if we're using a drain, it should be removed within 24 to 48 hours because there is no evidence that the drain improved the wound except, or there is no conclusive evidence except that it increased the rate of infection. So we should not maintain the drain by any means more than 48 hours, unless it's an infected cases. That's another issue. But for a primary case, the maximum is, I guess, 48 hours if we're using a drain. Yes.
Okay. طيب. Dr. Mustafa, if I decided this patient is infected and decided to do debridement and the implant retention, should I aspirate the joint first and identify the organism before I and stop antibiotics before?
So usually if you already have the decision that you will do there, then doing the aspiration I don't think will give you information, except if you are suspecting that your patient may have like a resistant organism that you may need to prepare, for example, a special antibiotic cement, because it will be okay. Now, since we already have like the new techniques for diagnosis like the PCR, so the result is back in 50 minutes. So if you do the aspiration, it will be good to know the organism prior. But the problem is if you are planning there, the more time you wait, the more likely you will fail. Usually it should be fast. So if you do aspiration and wait for 2 days in the best lab for the result of the culture, now this might be not like smart.
Okay.
But there was a very straightforward question in the last ICM 2018. Should the DARE be postponed until we get the results of the cultures? And the clear answer was no, and there was consensus that we should not wait till the results of the culture to go for DARE.
Okay.
When cultures are delayed, so it's not wise. But if you use the PCR, because we did the PCR in one patient, and actually we will publish this. We did intraoperative PCR. So the patient was in the OR and she had like a hip arthroplasty, and we needed the decision to remove the whole implant or not. So it was interesting to do the PCR, and that's what I told the surgeon. I told him, if this is a nasty organism, nasty carbapenem-resistant Klebsiella, then keeping the hardware and doing suppression would be very difficult.
If I knew from the aspirate or intraoperative cultures that the organism was a high valence MRSA or resistant drug, should I go for debridement and implant retention, or one stage? I should remove all the implants with high valent organism.
Okay, so it's not just only a medical and infectious disease question. The problem is usually it's also some social question, because you need to know that not always the joints are available here in Egypt, and who will pay for the price for the change. So there is a lot of things that we need to discuss together, right?
Okay.
But if you tell me pure medicine, if it's MRSA, I don't think MRSA DARE and single stage will be that successful in Egypt. My experience, I know it's not that good, but from what I see, MRSA has a problem in Egypt is that if you don't place a PICC line, start IV vancomycin, dose vancomycin per level, then there will be a high rate of failure, right? But if you have an MRSA patient with an appropriate treatment, PICC, vancomycin, dosing per level and labs, then you might go with DARE and the rate will be around 70% success.
And each patient you are prescribing vancomycin, you go for the level, you measure the level of the vancomycin?
That's what I just, socially, or just if I prescribe vancomycin. Every patient that is educated, they have to get vancomycin level. But it's the problem is that it needs the logistic to be arranged. But dosing vancomycin without level is like giving nothing.
Okay. Our last question to Dr. Wael.
ايوه احمد خلاص انا شفت يعني.
ايش؟
احمد والله ما احنا ليه لسه
شكراً.
الساعه لسه
احنا
6 وربع احنا 6 وربع. شكرا يا دكتور احمد سعيد على احنا ديسكاس الجزء بتاعت البريفنشن والايرلي بوست اوبرتيف. هنشفت مع الدكتور احمد سيد قطب عن حالات الكرونيك انفكشن.
Toxicology lab, we have vancomycin leveling. And we require the clinicians to order it because always our kit is going to expire.
So we can do it routinely for.
Yes.
And even in private lab, it's sent out to National Cancer Institute and the result within 1 hour. Or 57 hospital, result within 1 hour, simple. It needs arrangement of logistics.
Thank you, Chairman. Our case هتبقى عن chronic hip infection. This is 60 years old male patient, chronic kidney disease on regular dialysis, operated for fractured neck femur by cemented bipolar. He has a chronic infection for 1 year with draining sinus, and the patient was on oral antibiotic suppression for 1 year. ESR was 100 and CRP was 65. Professor Ganzouri, about this patient, as he is a chronic kidney disease and it's considered more morbidities should be considered in the management of this chronic infection. What do you think about oral antibiotic suppression in this patient?
Ahmed, the concept of chronic suppression or SAT, suppressive antibiotic therapy, is not just giving the patient antibiotic. As it was described, suppressive antibiotic therapy should pass into 2 phases.
Okay.
Phase where you give 2 or 3 antibiotics until the parameters of infection is going back to normal, then you shift to a safe oral antibiotic that is effective to that particular pathogen, and you can give to the patient over extended period of time. I don't think that patient was managed according to these criteria. He was given any oral antibiotic according to the cultural sensitivity, and that's why he has a draining sinus. And again, I have another objection. Using a bipolar on that particular patient, it was not the best option because he has, most of those patients have some kind of osteomalacia, like the case we were discussing.
Yes.
So you'll end up with that scenario, we have protrusion of the cup.
The patient has 2 problems, chronic infection and the protrusion. Okay, Professor Wael, the patient is dependent. He go to the sessions of the dialysis by his own self. So the patient, he refused for removal of this implant, so he decided to go with antibiotic suppression. If we will go with that patient with another way, depending on that it is dependent patient, what will you decide for him?
ده بتتكلم على البرايمري يعني لو
لا, for management of this chronic infection.
دلوقتي احنا we are dealing with chronic periprosthetic joint infection
Okay.
for 1 year. معناها انه established infection بالماتيور بايوفيلم. احنا وبالتالي احنا we are going for either 1 stage or 2 stage revision. If I could identify الأورجانيزم وإن هو susceptible للأورال antibiotics when I don't have a severe bone deficiency, I don't have severe soft tissue deficiency, and the organism is not difficult to treat, as mentioned by professors in infection, I can go proceed for 1 stage revision in case of this criteria. If any one of these are not present, so I should go for 2 stage revision.
Professor Mustafa, we will go for either for single stage or 2 stage. The patient was in oral antibiotic suppression for 1 year. Will we stop the antibiotics pre-operative?
So usually, if for an important notice regarding this patient, that patient with end-stage renal disease, they have another modality for suppression. Usually, those patients they go to dialysis center 3 times per week, so they have more option than the regular patient. In that, if for example they need suppression for MRSA, they can get vancomycin after each session. So that, or they get ceftazidime after each session. So they have more option than the regular patient. That's important for patients who have who are end-stage renal disease and go to dialysis.
I ask that he will be operated either for the single stage or 2 stage. The antibiotic suppression will be stopped pre-operative.
Sure, to get culture.
How long?
To get culture. So usually, whenever you have a patient that needs to have like arthroplasty, usually it should stop the antibiotic like more than 7 days. The recommendation is from 10 to 14 days. The longer, the better. But the problem is usually those patients, if they are septic, so that's against the stopping the antibiotic for longer time, because this will be dangerous for the patient. But now, since we have the new techniques, it's now easier. So whenever I order the tests for the patient for prosthetic joint infections, I order for the lab, please get bacterial culture, fungal culture, mycobacterial culture, plus or minus multiplex. So if they have the sample, because it's expensive. So if the sample doesn't grow after broth enrichment and extended culture, automatically they go for PCR. Some patients, they told me, okay, doctor, I will pay. I don't have a problem with the money. So I tell, okay, we can do the PCR up front. But usually the protocol, if the cultures are negative, you go for PCR. So that we have now more patients identified. Sure. Yes, and there is a very important thing in the PCR that we need to know. The PCR that we have currently available now in Egypt for orthopedic infection, which is the film array, doesn't have coagulase negative staph in the PCR, although this is the commonest organism causing prosthetic joint infection. I think they took it out intentionally because of this test is so sensitive, so you will be easily getting it picketing up from the skin. So to decrease this false positivity, they took it out. So this is very important. So whenever I see a patient that's having in the culture gram-positive cocci without like with culture no growth, and I see this thing, I say to the patient, most likely you have coagulase negative staph, and I start treatment for coagulase negative staph.
Cannot stop the antibiotics for this patient. الإفكت بتاعه على الكالشر.
It has a huge effect. It might suppress the growth of the bacteria. One of the cases, it is a real case scenario. I have encountered that she's about 42, female, and she has a septic knee. Okay, then she was in a very bad general condition. She came to our hospital, and immediately they did an aspiration of the knee, okay, and they sent us 2 samples, one for the culture and one for the film array, okay. The film array gave the result positive for Staph aureus, MRSA, okay, and the culture after 3 days, no growth. And this shows us the importance of the PCR, that even MRSA might be suppressed by the antibiotics because she was taking antibiotics for almost 2 weeks. Okay, so the culture was no growth, and she was given the targeted therapy on the basis of the film array result, and she improved dramatically.
And there is also an important point when you have a discrepancy between the PCR and the culture. For example, if the PCR shows an MRSA and the culture grew MSSA, so the recommendation as per the guideline, we discussed this before, is to treat as MRSA. So this is important. If there is discrepancy, I will go for the...
And the beauty of the film array that it gives the resistant gene as well. It doesn't say only Staph aureus. The film array contains 39 organisms, together with about 5 or 7 resistant genes, including the gene for MRSA. So it is definitely, it is a MRSA. Okay?
Okay. Professor Taimur, as Professor Wael mentioned, will you go for single stage or two stage exchange in this patient?
Two stage is always safer in the term of success of the surgery, not always safer for the patient. To make it easier an answer, we speak about who is a candidate for single stage. The patient who is a candidate of single stage is a patient who does not have a draining sinus, a patient whose general condition is not pointing to a chronic disease like diabetes, for instance, advanced diabetes, or any other immune deficiency condition. A patient that after aspiration you can get a favorable antibiogram by the lab. That's to say the patients who have negative cultures, for instance.
Yes.
Huh?
Always.
What kind of antibiotic you're going to give after the surgery, and for how long? So the main criteria locally is not an angry scar, especially if there is a sinus, no single stage. A patient with
even sir, you isolate the organism.
a sinus, active sinus is, in my opinion, against single stage.
Okay.
The types of organism I'm going to talk about later, whether it is in the sinus or in the culture. Number two is the patient's condition regarding chronic disease or immunocompromised status. Number three is the antibiogram. هو ده اللي انا لسه هتكلم عليه. الجرام نيجاتيف don't do single stage in a gram negative. Don't do single stage in an unidentified bug. Don't do single stage in multi-drug resistant bacteria.
Okay.
يعني عيان الكالتشر عنده مطلعها 3 انواع ولا 4. خدت بال حضرتك؟ كل واحد فيهم ممكن يكون الانتي بايوتيك از ديفرنت ذان ذا اذر.
اوكي.
يبقى الاربع عيانين دول ما تعملش فيهم سنجل ستيج.
تمام.
لو خارج الاربع كرايتيريا اللي انا قلتهم على حضرتك جايز يكونوا قدام شويه عن اللي انتوا بتستعملوهم دلوقتي. You go for 2 stage revision.
اوكي.
والتو ستيج ده له طريقتين. انت عارف دلوقتي احنا زمان هتغير التو كومبوننتس.
اوكي.
دلوقتي في فكره ان انت تغير كومبوننت واحده لو انت متاكد ان الكومبوننت الثانيه ما فيهاش حاجه. في لاين ما اعرفش انتوا بتعرفوه ولا لا، في العيانين اللي عندهم ادفانسد موربيديتي وكوموربيديتي ان انت تعمل soft tissue debridement, polyethylene exchange او head exchange او acetabular exchange لو هو باي بولر، وتحط ما يسمى بالبيري بروكسيمال فيمر سيمنت سليف، تحاوط بالذات في الحاجات اللي هي فيها كلوكي وبوند افكتس وبتاع، تحاوط الفيمر وتحاوط النك بتاعه البروستيزز بانتي بايوتيك سيمنت عليه الانتي بايوتيك اللي انت عايز تحطه.
اوكي.
دي طريقه اخرى غير الاكسشينج.
اوكي.
وشكرا.
Thank you. Either single or two stage revision, it should isolate the organism. And if we go for isolation of the organism in this patient. Professor Ibrahim, will you go for swab from the sinus tract or you will go for hip aspiration?
Ahmed, I think it was very clear that all the panel agreed that we should not go for swabs, skin swabs, because it might be contaminated and is not as accurate, and you should go for a proper aspiration.
Okay. What is your recommendation or prerequisite for hip aspiration in the OR, in the clinic, ultrasound guided or image guided?
Personally, I prefer to do it in the operation theater under image intensifier. However, if it's proved to be very difficult to run successful, I might resort to ultrasound aspiration. However, again, I might be a bit skeptical regarding the precaution they take using the ultrasound and the chance that it might be contaminated.
Okay.
So my first choice would be in the OR under CR.
Okay. Professor Mustafa. تفضل بيه.
Hip aspiration is not the ultimate investigation. The ultimate investigation هو بتاع الاندوكلينيك اللي انا بقول لكم عليها دي. The ultimate investigation is hip fluid aspiration and bone soft tissue core biopsy. يعني بيدخل كور وبيطلع لك ايه؟ بيطلع لك الكبسول بالساينوفيوم بحته عظمه من الاستابل. وده حاجتين.
Okay.
This is much more accurate وهو ده اللي وده بقى اللي مش هيطلع فيه نيجاتيف كلتشر. بالذات اللي هو فيه كور تيشو. الكور تيشو ده يا اما الكور تيشو ده بيبقى سوفت تيشو وبون.
The patient underwent hip aspiration, sent for culture, and the culture was negative. Professor Mustafa, we stop at here, or we can go for extended culture, BCR.
So right now, I think I will answer the question, me and Dr. Omneya, of course, in this question. But usually, meanwhile, in 2025, there is no patient that we don't do PCR now. All the patients we do PCR.
بس برضه الاكيورسي بتاعت البي سي ار for يعني what is the percentage of still we have negative culture with PCR?
So there is a possibility because as we just mentioned that the PCR has a certain number of organisms. So if the bacteria is out of this panel, they call it an off-panel organism.
Yes.
Usually, it's not that common. It's like you will pick up more than 95% of your infections. Okay? But you will be faced with culture negative. And I have seen many patients with culture negative. The most important reason for getting culture negative and PCR negative is usually prior use of antibiotics. Right? And the second thing
انت تقصد البي سي ار البايوفاير ولا مع النكست جنريشن سيكونس كمان؟
الفيلم array biofire. Because for next generations, so there are two types of sequencing. Dr. Omneya,
احنا we did have sequence next generation sequence in Inchams.
Yes, we have next generation sequencing in Ain Shams, but not for a routine use, for research in Masri only.
Sorry?
For research in Masri.
For research.
In Masri, in Center Masri, there is a next generation. But not for routine use. We don't have it in the main labs.
Okay.
It's quite obvious that the use of antibiotics might affect our culture results. How does it affect the results of the PCR?
The PCR will be positive. If the organism is present, it will be positive.
It does not.
Because
And
it detects.
that's the beauty of the PCR. It's
Yes.
not really affected by the antibiotics,
No,
right?
no. It detected the dead DNA.
if you use antibiotics for a long duration, then the count of the bacteria will decrease. Then the PCR sensitivity decreases also. Right?
You mean, Dr. Mustafa, you mean that the load of the bacteria will decrease, and this might affect the PCR. However, what I know is that it does not really change the results of the PCR, and that's the beauty of using the biofire, or what? Or am I wrong?
So, no. So he is asking that since already PCR detects the nucleic acid of the bacteria, then it should be positive in any patient as long as there is an infection. And you know the organism is in the panel, right? But I just mentioned that if you use antibiotics for a long duration, the bacterial load will be low, and the machine, the platform, the BioFire film array, is not set to detect that very low because they don't want a lot of false positives.
معلش هخش في another discussion. What I read is that one of the downsides of the next generation sequencing or the BioFire is that it's too sensitive, that it might find very low loads of antibiotic of bacteria that are not really infection.
Agree.
So
Yeah, but there is a difference. Dr. Omneya will tell you.
There is a difference between the techniques. If we are talking about the film array, the BioFire, which contains a lot of targets, they have a limit for detection because they are having a lot of primers and they are afraid of the primers get attached to each other and they give a false positive. But if we are talking about the singlet PCR, the PCR which detects only one, it is very sensitive. Because in the process, the technique contains an amplification process. So when I have one copy, I can end with millions. But this is not the case in film array. And there is a limitation for the film array.
thank you.
Professor Wael, the patient is a chronic kidney disease. We did the Hib aspiration, culture negative. We will go for 2-stage revision. In the first stage, what are the optimal sampling and processing techniques for the cultures obtained during the first stage? The number and the technique.
at least 5 samples at least from different areas. يعني ده مستخدم من الاستابلم سوبرا استابلر سوفت تيشو الجزء بتاع البوني سواء انتراميدالري اند اكسترا ميدالري او من الجوينت كبسول. sometimes برضو لو suspicious من اريا من البون اذا كان فيها جرو انفكشن ساعات بيبقى في ديبيت على البون بايوبسي. they cannot recommend with or against, but يعني if you suspected point في البون يبقى تاخد at least 5 samples.
Okay, Professor Ganzouri, you add something to the way we take the culture, the
I agree totally with Dr. Wael. However, it's better to take the cultures from the interface between the implant and bone. And also we should use different instrument for each culture to avoid cross-contamination. And also this will take us later on to where to put it and how to handle it.
Okay, Professor Omneya, there is a considerable time that I send the culture of the samples to the lab.
Yes, immediately. Immediately. You send the cultures immediately. It is on the spot. You have the OR in the.
طب which media do you prefer for the best culturing? Do you prefer the blood media or is original media?
First of all, if I'm talking about the specimen collection itself, I wouldn't recommend swab. Swabbing is the worst specimen to be collected, okay? Because the swab, either it is cotton or any other thing, it might be dry and kill the organism. So in many cases, we get a negative culture. This is first issue. The second issue, that whenever we get a specimen, a sample, we should immediately send it to the lab, okay? We can put aspiration on blood culture. It enhances the retrieval of the organism. Yes, we can do extended culture for it, okay? It's specific for some organisms like Cutibacterium, okay? But in all cases, I would recommend to do a PCR because we are doing a major surgery and the patient life depends on it. We should do the optimum. The PCR detects everything and anything, okay? Especially the firm array with its limitations, it might be very helpful.
And Dr. Omneya just mentioned a very important point that every orthopedic should know. Usually for bone cultures, it needs to reach the lab within around less than 30 minutes. So in my clinic, whenever I get a sample, I tell the patient, this sample should be in the lab in less than 30 minutes. And then whenever he asks a question, I tell 28 minutes. And he asks the next question, I say 26 minutes, please go now. So very important that you need to know that you need to send the specimen fast. Second point, if you aspirate a fluid from the knee, from the hip, put it in blood culture bottle, as Dr. Omnaya mentioned. That's the enrichment media to increase your yield.
احنا كده محتاجين معمل جوه اوضه العمليات يا دكتور مصطفى.
Exactly. You should have the bottles in the OR.
You got blood cultures every day and every minute, and the nurses come and take by 10 bottles.
And you need to know very important point. The lab, how the lab works, Dr. Nia will mention in Egypt, many labs, I have one lab that's in El Fayoum, and then the patient got the surgery here in Cairo, and he said, I got the sample and I sent it home when I returned after 2 days. Of course, no growth. So you need to know that the sample should reach fast, so it would be better to send to a core lab. Core lab.
No, the Bio5 will help us to know the type of the organism, but it will not give us the antibiogram or the antibiotics
Yes.
for that organism. And over the past years, we have been getting very funny outcomes from the cultures. Different organisms resistant to all types of antibiotics.
There are genes
So,
of resistance. You can anticipate the it's called genotypic susceptibility. You get the gene for
Yes, there's genes for carbapenem resistance and for MRSA and for enterococci resistant FANCO.
The function is a special recommendation, and I wrote in the report about a bacterial fungal infection.
لا يا بعد اذنكم يا جماعه، بعد اذنك، يعني بعد كل الدسكشن الجامده ديت، يعني سيبك من عملنا ايه. احنا وي نيد ريكومنديشن عشان اللي نعمله بعد كده. يعني انا بنيجي نتكلم السامبلنج تاخدها ازاي، PCR هنعملها ولا لا، والكلام ده انا اعتقد ده المهم ان اطلع بيه دلوقتي قبل ما انهي السيشن ديت. فبدل ما نقعد نكمل في الكيس ديت، حطوا لي ريكومنديشن دي في ساعتها. ما انا بقول لك حطوا لي ريكومنديشن كده عشان كل يعرف، ودي اللي هنمشي عليها كبروتوكول في الدمرداش حتى هنعمله.
Okay. So classic, any patient who is coming with prosthetic joint infection in the first time or doesn't have risk factors, it should send just bacterial, aerobic, and anaerobic. So that's the routine. Bacterial, aerobic.
Anaerobic, I should ask for a specific media,
Yes,
media before.
Either you get in a special bottle from the lab or put it in a syringe and get all the air out. So that's in the anaerobic. Okay? But, so that's for the routine. Bacterial, aerobic, anaerobic. But some doctors recommend bacterial and fungal as routine. They say, okay, this procedure costs hundreds of thousands, so I don't want to waste my surgery for an extra 200 pounds. So they request mycobacterial culture only for patients with suspicion of tuberculosis, failed multiple procedures, chronic infection, other risk factors for mycobacterial infection. Not routine.
Professor Ganzouri, the last. The patient, the cultures were negative, and I decide to do two-stage revision. The first stage, I do debridement and articulating spacer. What antibiotics will you put on the cement?
you can use actually a lot of antibiotics. You have almost very, very large number of antibiotics that can be added to the semen. However, it's better to be in powder form. It should be thermostable. And it should be the patient does not have sensitivity. The patient does not have hypersensitivity to that kind of antibiotic. You should give, if you know the organism, you should use the specific antibiotic. However, you should put antibiotics to cover both gram-positive and gram-negative. Basically, that's it. Double antibiotic. We usually use vancomycin in addition to the gentamicin. And you can add cephalosporins or any type of antibiotic according to the cultural sensitivity.
Okay. The results of the culture was, Professor Taimur, was Enterobacter sensitive to the tetracycline. My question, will you operate the patient, or will you decide a second debridement, or we depend only the antibiotics in the the period between the two stages. I add vancomycin or gentamicin on the cement, which is not typical to the culture result. Is IV antibiotics or oral antibiotics according to the result is sufficient, or we'll go for another debridement to the patient?
The tigecycline is a funny antibiotic. I'm not sure if it has cement or acrylic cement elution, if it is water soluble or not. You can actually add any antibiotic if you have these two criteria. هو heat stable and it is soluble. الاليوشن دي ممكن تدور عليها بقى. الاليوشن is the how good the antibiotic leaves the cement into the host tissue. فانا مش هتكلم فيه، انما هو طبعا تيجرسلين ده ما فيش لوكال تريتمنت. انما if I will put a cement in this patient, I will put at least gentamicin added، يعني اللي هو بتاع الشركه.
Okay, so this is a very important culture. I need Dr. Omneya to comment first and then we'll do. So, very common, carbapenem resistant, nasty Enterobacter. So, what's your comment? Colistin not tested. عشان ده المختبر. So this lab doesn't test colistin because colistin needs an extra charge. So colistin was not added. So yeah, and colistin is a very major important antibiotic to be added to the cement, right? So here it was not added. So what if the first thing I see this culture, I call the lab, I say, please do colistin testing by colistin agar or broth microdilution, because I need to tell the surgeon whether to add colistin in the antibiotic cement or not, right? Second thing, if you have tigecycline bone infection, you cannot treat with tigecycline alone. You need a combination of 2, 3, or 4 antibiotics, including colistin plus tigecycline plus others. You cannot give single tigecycline, not that much bone penetration, and even if it's the only sensitive antibiotic, should be added on another antibiotic regimen.
Okay, thank you. Thank you, sir.
وهنا بننهي الجلسه، ومتشكرين جدا. بشكر الدكتوره امنيه والدكتور مصطفى طبعا، يعني اثريتوا البانل، ودكتور تيمور ودكتور ابراهيم الجنزوري. شكرا جزيلا.